Good morning. Today we'll discuss ACE inhibitor-induced angioedema, a potentially serious adverse reaction that healthcare providers must recognize promptly. This condition occurs in approximately 0.1 to 0.7% of patients taking ACE inhibitors and represents a significant consideration in clinical practice. The pathophysiology primarily involves bradykinin accumulation rather than histamine release. Angiotensin-converting enzyme, also known as kinase 2, normally degrades bradykinin. When inhibited, bradykinin levels rise due to reduced breakdown. Bradykinin then binds to B2 receptors on endothelial cells, leading to vasodilation, increased vascular permeability, and plasma extravasation into subcutaneous and submucosal tissues. This results in non-pitting edema characteristic of ACE inhibitor-induced angioedema. The process is not immunologically mediated and does not involve mast cell degranulation or histamine release. Clinically, this condition presents with asymmetric, non-pitting edema typically affecting the face, lips, tongue, oral mucosa, and upper airway structures such as the larynx and pharynx. Notably, swelling around the eyes is uncommon. The condition is painless and non-pruritic, distinguishing it from allergic angioedema. Importantly, no urticaria or rash are present, supporting a bradykinin-mediated rather than histamine-mediated process. Regarding onset timing, contrary to the misconception of rapid onset, swelling often develops gradually. While approximately 50% of cases occur within the first week of therapy, episodes can appear weeks, months, or even years after starting treatment. Recurrence is common if the drug is continued. Gastrointestinal involvement may occur, presenting with abdominal pain, vomiting, or diarrhea due to intestinal wall edema, which can lead to misdiagnosis as an acute abdomen. The most serious manifestation involves laryngeal edema, posing a life-threatening risk of asphyxiation that requires urgent evaluation. For emergency management, immediate discontinuation of the ACE inhibitor is essential, as re-challenge is contraindicated due to high recurrence risk. Airway management takes priority in severe cases, requiring close monitoring for stridor, hoarseness, or dyspnea. Early involvement of ENT specialists for laryngoscopy is recommended, though intubation may be difficult due to distorted anatomy, potentially necessitating cricothyrotomy or tracheostomy. Standard allergy treatments, including antihistamines, corticosteroids, and epinephrine, have limited or no benefit because the mechanism is non-histaminergic. Specific therapies include icatibant, a bradykinin B2 receptor antagonist used off-label with case reports, suggesting benefit, though randomized trials show conflicting results. Fresh frozen plasma contains functional ACE, kinase 2, and may help degrade bradykinin, with case reports indicating rapid improvement despite limited robust evidence. C1 inhibitor concentrate has been used based on similarity to hereditary angioedema, but its efficacy in ACE inhibitor-induced cases remains unproven. Most cases resolve spontaneously within 48 to 72 hours after stopping the drug, though mild symptoms may persist longer. For prevention and long-term management, permanent avoidance of all ACE inhibitors is mandatory after an episode. Angiotensin receptor blockers are generally considered safer alternatives with a significantly lower risk of angioedema at approximately 0.1% compared to 0.1 to 0.7% for ACE inhibitors. However, cross-reactivity between ACE inhibitors and ARBs is reported in less than 10% of cases, likely due to shared downstream effects on bradykinin pathways, necessitating caution when switching. Angiotensin receptor neprilysin inhibitors are contraindicated due to their higher risk of angioedema. High-risk groups include individuals of African descent, women, smokers, patients over 65 years of age, and those with a history of seasonal allergies or prior ACE inhibitor cough.